Hey guys, we're going to be going over cell trafficking. Cell trafficking is how proteins are sent to one place or another in the cell. The main player here is a Golgi apparatus, which is kind of like a specialized endoplasmic reticulum that has some modifications for packaging molecules before they are exported to their final destination. This is a scanning electron micrograph of a Golgi apparatus. You may actually be required to recognize this on your exam, but luckily the Golgi is pretty easy to recognize. It basically looks like a cross-section through a stack of pancakes, and sometimes you'll be able to see these little vesicles coming off of it. As I mentioned earlier, end-link glycosylation occurs in the rough ER. However, these end-link oligosaccharides can be further modified in the Golgi. Also, O-link glycosylation occurs exclusively within the Golgi and only occurs on serine and threonine residues. Here we have serine and here we have threonine. So what is O-link glycosylation? Well, it's similar to N-linked, except now we're adding the oligosaccharide to an oxygen atom that's on a serine or threonine amino acid, which is why it's called O-linked. So here are the amine and carboxyl groups that all amino acids have, and here are the oxygen atoms that O-link glycosylation adds sugars to. So like I said before, the Golgi is mostly known as the distribution center of a cell. How does it know what needs to be sent where? Well, specific modifications on proteins can target them to different organelles. And the most important example of this for your exam is that adding mannose-6-phosphate to a protein targets it to go to the lysosome. So here we have mannose-6-phosphate, which is just a mannose sugar with a phosphate on its numbers 1, 2, 3, 4, 5, and 6 carbon. If someone is unable to add mannose-6-phosphate to a protein, where are these proteins going to go instead of the lysosome? Well, they'll be secreted out of the cell, and this will result in a disease called I-cell disease. I-cell disease, or mucolipidosis type 2, is an inherited lysosomal storage disorder, which is super important for your exam. It is due to a defect in N-acetylglucosamino-1 phosphortransferase, which I know is a super long name of an enzyme, but this leads to failure of the Golgi to phosphorylate mannose residues on glycoproteins. This results, as we just mentioned, in proteins that are secreted extracellularly rather than delivered to the lysosomes. So how can you diagnose this? You can do a lysosomal enzyme test. This test measures certain enzymes such as alpha-monoxidase, alpha-fucosidase, and beta-glucuronidase in leukocyte cells, skin fibroblasts, and plasma. Activities of these enzymes will be low in both leukocyte and fibroblast cells because of the defective N-acetylglucosamino-1 phosphortransferase enzyme, but will be 10 to 70 folds higher extracellularly in plasma. Knowing this little fact is low yield for your exams, but it may impress some doctors once you get to the wards. So patients with I-cell disease will have coarse facial features, clouded corneas, and restricted joint movements, and it's often fatal in childhood. Here's a photo of a baby with I-cell disease. So this might show up on a test as a really sick baby with increased lysosomal enzyme activity in the plasma, and they may ask you which of the following mechanisms is responsible for the disease, and of course you'll pick defective N-acetylglucosamino-1 phosphortransferase enzyme. And again, this leads to failure of the Golgi to phosphorylate mannose residues and decrease mannose-6-phosphate on glycoproteins. The Golgi is also important for assembling proteoglycans, which are proteins that have lots of polysaccharide chains attached to them. They are often secreted in the extracellular matrix and used as a cushioning filler substance. So where do you think you might find it? There's a lot of proteoglycans in cartilage and in joints, and one of the main ones is chondroitin sulfate, which, as you can tell from the chondro in its name, like chondrocyte, is an important part of cartilage, and people even take this as a dietary supplement for osteoarthritis, though I think it's still questionable as whether it actually works or not. Lastly, the Golgi is where many post-translational modifications are added to both proteins and proteoglycans, such as the sulfation of tyrosines on some proteins. Now let's talk a little bit more about vesicular transport to and from the Golgi. So the Golgi is found between the rough ER and the cell membrane. And the cis Golgi is what we call the side closest to the rough ER, while the trans Golgi is the side closest to the plasma membrane. There are three main proteins that organize traffic to and from the Golgi, as well as between different layers of the Golgi. COP1, which stands for coat protein 1, is involved in retrograde transport from the Golgi back to the ER. It is also used to bring things from the trans Golgi back towards the cis Golgi. So basically, it works in bringing everything in this direction. COP2, or coat protein 2, does just the opposite. It causes anterograde transport from the rough ER toward the Golgi. You might have your own way of remembering this. I like to remember, first you walk in, then you walk out, as in walk into the cell and walk out of the cell. Your book has this way to remember: 2 steps forward for anterograde transportation and 1 step backwards for retrograde. Really, whatever works for you, but make sure you have this in order. I've seen so many questions on COP1 and COP2 asking the direction of transportation. Lastly, clathrin is important for receptor-mediated endocytosis. The direction it helps facilitate is also important. It moves vesicle from the trans Golgi to the lysosome, and from the plasma membrane to endosomes. When something is endocytosed from the extracellular environment, it is first stored and handled in a temporary organelle called an endosome. Depending on what the endosome contains, it can be sent to a lysosome for degradation, or to the Golgi for more processing, or even back to the membrane. Why is clathrin important? Well, aside from what we just mentioned, it is also important for LDL receptor activity. Here's a picture from your first aid book depicting all the lipid-lowering agents. We'll be focusing on this section here, but I'll quickly go over the cycle. So when we eat fatty foods, cholesterol is broken down in our digestive tract and absorbed in the intestinal lumen into enterocytes as chylomicrons. Chylomicrons are then transported to our blood via lymphatics, and from here we can make free fatty acids, HDL, or triglycerides in the liver. Triglycerides can then be metabolized to cholesterol or VLDL. VLDL is transported to our blood vessels and can form free fatty acids or LDL. After LDL is formed in our blood, it binds to LDL receptors. And these LDL receptors are clathrin-coated LDL receptors, as we discussed earlier. There is a gene called PCSK9, which stands for proprotein convertase subtissulin Kexin type 9, and this functions by reducing the number of LDL receptors on the plasma membrane of hepatocyte cells. What happens if LDL receptors are not available to transport LDL to the liver? Well, there will be an abundance of LDL in the bloodstream, and this is when medical problems come into play. Too much LDL in our blood can saturate our vessels and cause atherosclerosis, which has a whole slew of health problems. In 2015, the FDA approved 2 PCSK9 inhibitors, alirocumab and evolocumab, with goals of lowering LDL concentrations. Though the mechanism of action seems great, these drugs cost a pretty penny, around $14,000 per year, which ends up being more than $1,000 a month. So statin drugs continue to be the drug of choice in treating high cholesterol. So back to our main discussion. The reason I bring this up is because you may get a question stem discussing a patient with hypercholesteremia who has failed multiple statin drugs and is now being prescribed a PCSK9 inhibitor. The question can ask you what process is increased by the use of this drug, and the answer would be clathrin-mediated endocytosis. Now let's try a flash quiz. Mannose-6-phosphate is added to proteins to direct them to which organelle? That would be the lysosome. And remember, if this mechanism is defective, you will get isol disease and the protein will move extracellularly out of the cell instead of the lysosome. Thanks for watching. If you liked this video, don't forget to give a thumbs up.